Good evening. I want to welcome everyone into the webinar. The title of this webinar is Caries, Silver Compounds, and Glass Ionomers. My name is Dr. Jason Hirsch. I want to start off with telling everyone a little bit about me and why I'm here tonight discussing this topic with everyone. So I'm a pediatric dentist. I'm in private practice in Royal Palm Beach, Florida. It's a suburb outside of West Palm Beach, and it's a fairly mixed population of people of all socioeconomic statuses and races. I see a good varied mix of patients on a daily basis, so I think the insight that I'll present to you tonight, or these strategies or treatments or rationales or ideas, can assist anybody. I don't think this is exclusive for one population versus another. My educational background is I have a DMD from Nova Southeastern University. Just to give you some time reference, I graduated from dental school in 2002. Prior to dental school, I received my master's in public health at Columbia University. I graduated there in 1997. So I did my public health degree before I did my dental degree. I think that has some influence. Maybe I'm being downplaying that. I think it has how I practice, who I am clinically, where I see dentistry going or where it's been. And I think that's an important part of who I am. My pediatric certificate was done at Miami Children's Hospital down in Miami, a fairly robust and well-known children's hospital. It's a very well-established program, and I certainly had 2 good, solid years there of training. I want to say at this point, I think that this is a very, very exciting time in pediatric dentistry, solely based on the stuff that we'll discuss tonight. In the 14 years that I'm practicing, I have not been this excited to try and combat this problem that I've been trying to combat for a long time. I know anyone on this presentation is probably feeling the same way, that caries is just something that is kind of out of control in certain people. And this whole rationale is trying to understand how to get caries under control, understand a little bit more about the disease itself, and understand some of the ways that we can clinically help patients, because we are very much under the gauntlet of how effective can we really be to our patients, given the concepts, the ideas, the treatments that we were taught, that we were licensed to, all of those things. I think when we look introspectively at what we're doing on these caries procedures, we might find that we need to put more efficacy into what we're doing. And so my journey through private practice and understanding is really from the concept of causation from public health school. Like I said, it's been a huge part of who I am as a practitioner. But it made me realize after I finished my residency in pediatric dentistry that if we don't grasp this concept of causation, then we're not really giving our 100% to our patients. If all we're doing is just chasing a disease with gluing things to the tooth, then I think we're missing out on a large part of the problem. And unfortunately, causation is not really expressed in dentistry in general. It's taught a little bit in dental school. I don't know, maybe it's, since I've left dental school, maybe it's increased, but I find that hard to believe, because there's just so much technical skill that is trying to be condensed into a 4-year education to get people to be competent enough to practice on people, the general public, without us hurting people or killing people in the process. So I think practitioners get to a certain point in their careers, they start looking at things a little differently, and maybe I just started a little bit earlier in this. I've noticed that all of the techniques that we have in our arsenal are really just prevention of pain. Our clinical prevention's effectiveness is really, really small. These prophylaxis treatments that we render are not preventive. Sodium fluoride is not really very preventive. And we're constantly battling this time constraint of, it was explained to me there's 8,760 hours in a year. And if a patient is in our offices 2 hours, they're on their own for 8,758 hours. How effective really are we in these prevention appointments? And so I think we have to really start looking at true prevention, obviously, as primary prevention. And the prevention that we're delivering is really secondary prevention, which is just merely preventing pain. And I think that this presentation tonight kind of gets in between the two categories of prevention. It's kind of like a hybrid area, because these silver diamond fluoride, silver nitrate, these topical antimicrobial, antibiofilm medicines really get us in between, I feel, and hopefully you'll see this by the end of the presentation. Certainly, if anyone has any questions, just chime in there with them, and this is my first Viva presentation, so I may be a little slow on all the questions, but go for it. And I'll just go through the presentation, and then there certainly will be plenty of time for questions at the end as well. So keep going on how did I get here. After spending many years in pediatric dentistry and observing the traditional techniques not holding up to the underlying disease process, I started reading. And when you start reading, you'll see there's tons of clues in the literature that drilling and filling is really not it shouldn't be advocated for children, certainly not to the point that we have evolved to at this point in time. We want to think of us as being very modern and technical dentists, and all of this has been fashioned by high-speed handpieces and these composite materials and these glass ionomers that we're going to discuss. But again, this all falls under this category of what are we treating? Are we treating the disease, or are we treating the signs and the symptoms of the disease? And if we're only doing half of it with the technical skills that we were given, then we're leaving our patients in the lurch. We're leaving them to the wolves of those 8,758 hours that they're on their own. And it's obvious in a lot of these patients that are coming to us with problems, they can't manage the 8,758 hours on their own. There's something awry. And when you go back, you can see as far back as G.V. Black in the literature, he didn't treat children with drill and fill. Well, first, he didn't have drills, where he was right at the cusp of these inventions. But he used silver nitrate and he used zinc phosphate cement to rehabilitate his pediatric patients. And if you go back and you find his books, which are available, his textbook of operative dentistry, there's a whole chapter about how he treats children, and I recommend it highly to anyone, because this guy was you could read his stuff and you can cross out the name G.V. Black on the front of the book and the date of the title or the date of the printing of the book, and you can read what he wrote, and it could be 2016. You think that someone wrote this, and you realize he wrote this in the late 1800s, early 1900s. I mean, the guy was way ahead of his time, and after reading his stuff, it just got me thinking that if it worked for him in the 1800s, there's nothing different about the disease causation today than it was then. So why do we have a different rationale? And if we did bridge or switch to this drill and fill rationale from what these early dentists were doing, like G.V. Black or Percy Howe, and these guys who were using silver nitrate and zinc phosphate cements, and when we deviated from that point in time, what is so superior about the drill and fill that should make us stay on this course? And if you look at the Centers of Disease Control data that comes out of there, they do these reports, annual reports, decade reports, when you look at all these reports for like the past 50 years, caries is not under control. So clearly the concept of drilling and filling is not fixing the disease itself. It's just fixing the teeth. And again, I just think if we're only going to do 50% of the battle, I think we're leaving our patients out in the breeze. And so there's one really, really good modern book out there I recommend people pick up. It's by Edwina Kidd. She is a British microbiologist, and she authored a book called Dental Caries and elicited a lot of experts from around the world. You have to remember this is a global problem. This is not a United States problem. Every child on this planet is at a considerable risk of developing dental caries strictly due to the diet that everyone has basically been accustomed to, which is eating a lot of fermentable carbohydrates. And I don't see that changing. So let's discuss caries a little bit, just to start so we can get a background, and then we can get more sophisticated into how I'm treating children these days in my clinic. Dental caries is a bacterial and a behavioral disease process. Dental caries is the same in children and adults. The only difference is within the biological differences of primary and adult teeth. And once you understand that this is a process, it's not something that can be shut off or turned on by interventions that come from our office, you start to look at the problem and the solutions we have differently. If our fillings were cures, if the stuff that we were taught in dental school, if all of those basic level dental treatments were cures, then we wouldn't see a lot of the sequelae that we're seeing clinically, secondary decay and whatnot. So dental caries is found in almost all humans. I'd have to think that all of us have the caries process in our mouths. And it just is a point in time where the process turns from normal and beneficial to something dysbiotic, meaning the bacteria, these biofilms that are ubiquitous in all of us. And there's maybe over 700 different types of oral bacteria that we know about now. There's not one that predisposes any of us to getting tooth decay. It's the conglomeration of all of these bacteria working together, and somehow in the process something goes awry and turns these normal biofilms into something that demineralizes teeth. Again, looking at the evidence, the CDC data shows us, and I've got to believe this is 100%, that we all have dental caries. And so if you understand that caries is a process, it's a disease, but cavities are the clinical manifestation, we have to separate those two terms. These two terms have been conflated by dentists. And I think we're all a little bit confused. You can't have a disease also be the symptoms and the signs. There's no other disease that's out there where there's that conflation. And I think that this is really holding us back, or did hold us back for a long period of time. I think now with the things that we're going to talk about going forwards, and all of these silver compounds and the understanding of biofilms on a more sophisticated level, I think we're going to start to see the separation between these two terms. And I think because of the separation, we will start to see different therapies come about. And we'll talk about one going forwards in this presentation. But I really, really strongly believe we have to start to make the distinction that caries is a disease process and that we all have it. And there are certain things in certain people that turn it on and certain things in certain people that turn it off. But the cavities are just the manifestation of when the process gets turned on and it goes out of control. So when you look at the medical literature, dental caries is considered a medical disease of digestion. It falls in the gastrointestinal disease code section of the ICD codes. And that got me thinking that, look, it is just a disease of digestion. You don't get dental caries if you don't eat food. And that's a hard concept for a lot of people to understand, because we want to think of all these bacteria as harmful to us, but the bacteria, these biofilms in our mouths, they're beneficial. Just like every other part of our body is consistent of bacteria. I think the human body is 90% bacteria, something like a 3-to-1 ratio of germs to self cells. And so to have a concept where we're trying to eradicate germs, it just doesn't hold up anymore. It doesn't make sense. In a quest of sterilizing our mouths, we'll probably wind up killing ourselves, because, like I'm saying, it's a part of digestion. We have to have these bacteria. They help us digest our food. It's just the types of foods that we're eating is exacerbating the dental caries disease process from taking over. We all have to also understand dental caries is 100% preventable. There's no genetics that predisposes someone to not being preventable. It's nonsense. It's 100% preventable. It's a behavioral problem. And we have to start discussing this frankly with our patients. The basic way of thinking about dental caries is the minerals that get leached out of the tooth from the process must be accommodated by the same or more minerals in replacement. It's a simple concept. If we're going to eat, which we all like to eat, and if we're going to eat fermentable carbohydrates that are high in sugar, then we better understand that if we do that, we have to offset that behavior with something else beneficial. And that's where fluoride has come in. It's been a real incredible public health measure. It's probably the single greatest public health measure that's ever been in the history of man. It's got to be fluoride. And if we think about it, fluoride toothpaste has only really been available for patients maybe since the 1950s or 40s. We didn't have this when G.V. Black started. So maybe his thinking would have been different if there was readily available sodium fluoride toothpaste. But we have to understand now that is the single greatest gift that we've been given, and we have to use it. And we have to advocate for its use, and we have to put it back in the drinking water in a correct level. And we can't succumb to pressure that fluoride is harmful, because it's just nonsense. And so, sorry I got sidetracked there. That's my strong feelings on fluoride. But we have to understand that the demineralizations and the remineralization process are constantly ongoing natural biological processes. And we're not going to stop demineralization from happening. But what we have to do is understand how to remineralize, and how to teach our patients how to remineralize, and how to do procedures that are remineralizing procedures. Here's a couple of things. Is caries an infectious disease? I think every country on the planet besides America, maybe Canada still, every other country on the planet has ruled this out as an infectious disease, except America. And I think it's important that we start considering that this isn't an infectious disease. Yes, bacteria must be transmitted from somewhere to the infant who is born with no germs. So obviously, if you want to call acquiring germs an infective process, I guess then you could make an argument that it's an infectious disease. But caries is ubiquitous. Like I said, everyone has the ability to have caries in their mouth. In fact, everyone has the caries process happening in their mouth all the time. We have to start believing that. It's the truth. Again, here's this: humans are 90% bacteria, and a 3-to-1 ratio of bacteria to human cells. And again, there's no way to sterilize the oral cavity, gingiva, or teeth from these normal ubiquitous floras. what we have to do is learn to recognize when these normal biofilms go awry, and we have to have ways of treating these biofilms during the 8,758 hours that these patients are on their own. So our traditional techniques are with dealing with caries in children, and this applies to adults too, but obviously this is my field, is pediatric dentistry. Fillings repair cavities, but do they prevent new cavities? And I think overwhelmingly the answer to that is no, except it depends on the material used to repair the cavity. And this is one part of dental school that was very weak, in my opinion, and I have a feeling it's weak in general everywhere. Glass ionomers just is not taught in dental school. And I think that's a really, it's a big mistake. I think for a lot of reasons, glass ionomers have gotten a bad rap. And I think a lot of it has to do with our own ego and our own, we're so involved in the artistic part of dentistry that we are forgetting the science, I think, to an extent. And we're so hung up on restoring teeth to look like exactly how they did prior to this disease process. And when you start thinking about the disease process itself, when it goes awry, it occurs in three areas, right? It occurs on smooth surfaces, on facial aspects or buccal aspects or lingual aspects. It occurs in pits and fissures, and it occurs between teeth on smooth surfaces. So when you start to realize there's only three places that you can get caries, and that these three places, we're so enamored with trying to replace a lot of the anatomy that's causing the problem in the first place, I think when you get outside of that box of trying to do everything from an artistic standpoint and judging one another from this artistry of dentistry, instead of looking at and judging one another, are we using the science to our advantage? Are we doing everything we can scientifically with medicines like these silver compounds and these great materials like glass ionomers? We have to start looking at that. And so that's also part of my journey here, is that I started reading the literature on glass ionomers. And glass ionomers should be, I don't know why they're not, termed as medical devices that prevent caries. They should have a specific labeling on their packaging. I don't know why they don't. But I think that would be really, really nice if we could get some products out there and talk to patients about these products that we have that work to help these patients that are caries prone and will help them in those 8,758 hours that they're on their own. And I think glass ionomers fits this bill. But for whatever reason, dental schools don't advocate the use. Maybe they're technique sensitive, or maybe there's just been some bad experience from them over the years. And I think that they're just giving, dental schools are not giving glass ionomers their due. Maybe I'm wrong. Prove me I'm wrong. But I think when you study glass ionomers and you study how easy they are to use and you see how effective they are in the treatment of caries, I think you'll bridge that gap, maybe that practice phobia of wanting to use a new product, but the fear of it failing and patients coming back with failed restorations. And we always have this fear of failure. I think as dentists, we get stuck into this box that everything we're supposed to do for patients is supposed to be this technically excellent artistry and blah, blah, blah. And I think we get hung up, or we get scared of wanting to go outside of that window. I encourage you to go outside of that window. That's what you have a license to practice for. And that's what these patients are coming to see us for. If we have something that can help them that's outside of the box and we withhold it from them, I think we're doing people a real disservice. We shouldn't just be hung up on tradition. I think we have to look towards science. So how did I synthesize all this information about what I've said and what I'm going to say in the presentation? So a few years ago, the AAPD put out a really, really fantastic Carey Symposium. I think it was in Chicago. It's probably 10 years ago now, and I heard a lecturer by the name of Peter Milgram, a lecturer, fantastic researcher, clinician, academic. He's over at the University of Washington, but he started discussing this topic of silver diamond fluoride in this lecture, and it just really intrigued me because everything he was saying about it sounded like it's the perfect pediatric dental medicine. And I just followed it for many, many years, and luckily enough, this Peter Milgram guy, he really pushed hard to get silver diamond fluoride into this country, and I thank him for it, and I thank everyone else who's really made the effort to get us these medicines, because they are groundbreaking and truly going to help this problem. So I stumbled upon tons of dental literature about these compounds. I read as much as I can. There's a great website out there called, the website is www.mmclibrary.com, and I'll put it later on in the presentation. If anyone's interested in going to this website, I'll leave you the web address. But it has all of the dental literature going as far back as G.B. Black about these compounds, and it's fascinating stuff. I encourage you, if you're interested in this, to go there and read this. I realized that the discontinuation of silver nitrate occurred due to the advent of local anesthesia and community water fluoridation around the 1950s. That really touches home to me. I think there was like a fork in the road. I think G.B. Black passed away in the late 1920 area, 1930, somewhere in there. And between the 20s and 30s and 1950, there was these bickering back and forth between how to treat children using either silver nitrate at the time or doing more traditional fillings and whatnot. And you can go back and look in the archives of the American Dental Association and the National Dental Association journals, and you can see that I'm saying is completely factual. And then somewhere around 1950, they're just stopped. This complete stopping of silver nitrate use in this country on children. And it has to be because we invented cheaper hand pieces, local anesthetic, and we started fluoridating the communities. We found out what this sodium fluoride was, and we started advocating using sodium fluoride. I guess we thought maybe that would be our silver bullet in this country. But other countries were having bigger problems, like Japan following World War II. And it's very interesting. They realized, the ministers of health there realized that they had a huge caries problem because they couldn't grow any food in their country after the nuclear bombs exploded. It basically made the place a toxic area so that they couldn't grow food. So they were dependent upon other countries supporting them with exported food. And of course, the Americans exported a lot of processed foods to them to help them survive and recover after the war. And all of a sudden, caries starts going out of control in this country. And the ministers of health there realized they had a problem that they couldn't fix with drilling and filling. And so they turned to the literature, and they found G.B. Black's writings on silver nitrate, and they studied silver nitrate almost like a mini Manhattan Project for Japan's caries crisis. And they realized that they had to get silver nitrate back into the population. But in their study of silver nitrate, they realized that there were some drawbacks to it. And remember, at the time, there's no over-the-counter toothpaste with fluoride in it. So some of the negative effects of silver nitrate are as a result of not having fluoride in the mouth on a constant basis. And so they realized if they married silver nitrate to fluoride, they could eliminate some of the negatives of silver nitrate therapy alone, and they can create this new compound that would help with their caries problem. And lo and behold, they did. They started basically swabbing silver diamond fluoride everywhere, and they started to get a handle on their caries problem. And I think it's pretty amazing that a country as resourceful as that, after a time of crisis, figured out that they needed to do something different, and they took action. Kudos to them. So going on with our my synthesizing of all this information and how I put it into clinical practice, I started reading about complete caries removal, and I started having feelings about it myself, because there's nothing worse than trying to treat a patient with some fairly, good-sized demineralization or decay, and there's nothing worse than telling a parent you're going to go in and do a simple filling, and then the next thing you know, you have one of those oh crap moments where you're trying to excavate all the decay because you're taught that that's what we need to do and all this other stuff, and you end up in the nerve, pulping out. And it happens to all of us. You chase decay, and the next thing you know, you're in the nerve. And, it's just not comfortable, because you know that once you're in the nerve, you've got to make some drastic decisions, and that wasn't part of the treatment plan. So you also have a patient in the chair. You have to think about that. You have to be conscious of that little person and what you're doing. And the technique of caries removal or complete caries removal, to me, it's just a bad idea. And I think it's an especially bad idea in primary teeth. I think, first of all, I think complete caries removal isn't attainable. Because again, this is this conflation of the disease process and cavities, right? If we understand that caries as a process and not something tangible, then how can you remove something that's not tangible? It's just not possible. So I think we've started using some really bad words, and we've carried them on as part of this tradition, and I think we just have to unwind them. And I don't think it's very difficult, because I think the science is going to give us the answers of unwinding this properly. And we know now that sealing in tooth decay is a more appropriate and evidence-based technique. And it's just going to take all of us as practitioners to grasp that concept, swallow it, and move forwards with it, because it's going to help us in the long run treat our patients better, more effectively. And as a result of that, patients are going to start coming back to our offices. The utilization of dentistry, pediatric dentistry in this country, is not good. It's hovering at 50% of the population of children. So 1 out of 2 kids, whether they're in Medicaid or whether they're in private insurance plan, are showing up to our offices. And that to me is disturbing. And we have to do something to bring these patients back into our offices. Using silver compounds to arrest demineralized dentin rather than surgical amputation is really a non-invasive idea. It's a truly non-invasive care rationale, and it leads me to this SMART technique. When teeth can be arrested, remineralized, and sealed, we can ensure that the latest evidence-based techniques have been employed. So combination therapies is something that is routinely used in other aspects of medicine. We go through many different diseases that have combination therapies, not only combinations of drugs, but combinations of a medical approach and a surgical approach. And so in this instance, the SMART technique that we're going to discuss shortly is just a combination therapy of, it's kind of like a hybrid combination therapy, because we're not going to do the surgical aspect, but we are going to do the restorative aspect. But we're going to add this component of medical or topical management of tooth decay and biofilms to address the ongoing process of caries that's always on in the background. And so I thought, what can we do in pediatric dentistry to employ a combination therapy? And through this reading of all the literature that's out there, and I stumbled upon this idea from a couple of practitioners who are out in the Pacific Northwest, who came up with this. I don't think they did themselves. If you look around the world, there are practitioners on other continents and other countries who are employing these two technologies of silver fluoride and glass ionomers with very, very, very high levels of success. I can attest that in the past 18 months since switching over to this idea, this concept, this rationale, I've extracted 3 failed teeth that I've personally treated with this therapy. And I can tell you that those 3 teeth I knew would fail because the decay was too far gone, but these patients were so traumatized from the other traditional drilling and filling that we just had to do something to keep the biofilm on these teeth that we treated this way, and to keep some of the discomfort that they were having to a level that would buy us some time for the patient to gain some trust again in dentistry and allow us to remove these teeth. But I really have not seen a failure of this technique in 18 months. So where it was correctly diagnosed radiographically is a help in this. But I haven't seen a failure. So that to me is extremely promising that this combination therapy really is going to work long term. Glass ionomers are dental materials that are used for caries control in humans. Glass ionomers are formed from a chemical reaction of finely ground glass particles reacted with polyacrylic acids. This is a little bit of the basics of glass ionomers. When the 2 parts mix together, a reaction product starts as a gel and works towards a solid state, which ionically bonds to tooth structure. Glass ionomers are hydrophilic materials, and that's very important because teeth are full of water, and we have to use materials that are in symbiosis with the medium that we're gluing these things to. I don't want to bag on composites. They have their place in dentistry. I think it's been a little bit overdone, but composites don't allow the tooth to behave the way it's meant to behave. And so I think that's an important point that is often overlooked on glass ionomers. Glass ionomers release large amounts of fluoride in the first few hours and first few days and first few weeks, and then that release tapers off. But the release of fluoride is really what we're looking for. I mean, these are medical devices. They're basically like slow leaking pills almost. Like if you could take a fluoride pill and glue it to the side of your tooth where it's just releasing fluoride slowly over time to help our mouths, not only with the caries process, but with also keeping our teeth intact to not allow the process to start again. So these restorations are important for making us understand that trapping food or trapping plaque in certain areas is aiding the process. Restoring teeth with glass ionomers, not only does it make the teeth look good, but it provides a function where teeth can behave like they're supposed to behave. Glass ionomers can absorb exogenous fluoride, so that's important. If your patients are brushing their teeth with fluoride, they're recharging these glass ionomers, which then release the fluoride back out into the mouth. So we've got this 24/7 slow bleed of low amounts of fluoride, which is really going to help our patients in the caries process and in that 8,758 hours that they're on their own. Glass ionomers, for anyone who doesn't know, they're superior sealing materials. They actually seal. If you put your 2 hands together like you're going to clap and hold your hands together, that's how a glass ionomer adheres to a tooth. It's a flush seal, whereas we know composites and resin-modified composites are the resin tag system, so it's more like your fingers intertwining with one another, and we know that there's gaps in between. That is what makes the caries process continue in restorations that are made out of composites. That's why we see it as composites. The biggest issue we have is recurrent decay. We don't see as much recurrent decay or at all when we place glass ionomers. So glass ionomers prevent marginal decay. Glass ionomers are easy to apply in children, and that's huge due to their moisture tolerance and their hydrophilic nature. Being able to treat children with just your fingers and some very benign looking instruments is going to go a long way for anyone who hasn't tried this in children. It's just not scary. You don't see drills and sharp things, and it just makes the life of a practitioner better because the patient is going to have a better experience. And remember, there's 3 parts to being a good clinician. Okay, the 3 parts, or this new triple aim of care, has to be that what we do helps the population's health overall. We have to also be aware that it has to be a good experience for both the patient and the practitioner. And the last thing is we have to make these treatments cost effective. So I'm not saying that we have to make them cheaper. I'm just saying we have to make them have more value. And I believe that glass ionomers have more value because they offer this caries inhibiting or this cariostatic mechanism behind them. So let's talk about sealants. Sealants are really our only true primary preventive agent. And it maybe could be argued that they're not really even primary prevention. I like to think of them as primary prevention. I guess if you're sealing over a fissure that we don't know if there is caries process taking place inside that fissure, that are we now in secondary prevention? It's kind of all semantics. I think if we want to think about them correctly, sealants are primary prevention, and especially glass ionomer sealants, because they are releasing fluoride and because they are able to be used during the eruption of teeth, of molars, during their process of eruption, which you can't do with resin because of the moisture tolerance of, or intolerance of resin materials. So I really think it's a primary preventive, but we could argue about that, I guess. It's a good point here. Glass ionomer sealants are as effective as resin-based sealants. There was a great evidence-based meta-review that was in, I believe, the August, maybe the September JADA. It was also in the AAPD journal, showing that with good evidence that glass ionomer sealants are as effective as resin. So there really shouldn't be this one is better than the other. And also that sealing over caries is a proven strategy to arrest the decay process. Sealing permanent molars during the eruption process is a direct advantage of glass ionomer sealants. The fluoride release from GI sealants during the eruption process provides primary prevention. Studies show that distal surfaces of second primary molars have less demineralizations when 6-year molars are sealed with GI. Here's, since SDI, Southern Dental Industries out of Australia, has been kind enough to promote and sponsor this talk tonight, and I use their products exclusively. I think they're very high-end products, from the packaging all the way to the actual product itself. They are fantastic products. This is the glass ionomer sealant that I use. It's a fantastic product. I encourage you out there to inquire, and at the end I'll give you a code for some discounts for products. I really like this stuff. It handles well. It's very professional looking, and the clinical results, when the patients return, I see the glass ionomer sealants in place. I see all of the materials that I'm using. I see them functioning like they're said they're going to function. And that's really important for a clinician, is to know and have confidence in the products that they're using. So here's Riva Protect. Fuji Triage is another good product, but we're going to talk about Riva Protect here and compare it against Fuji Triage, and we see that this fluoride release of Riva is just a little bit stronger for a little bit longer. And obviously a typical resin sealant is not releasing any fluoride. So we have a distinct advantage when we're using glass ionomer sealants. I have a question here that says, Triage glass ionomer sealants work easily and stop caries. How can we promote the use of this modality in dental schools? I think the easiest way to answer that question is that we as private practice practitioners and the educators in the dental schools have to just start pushing to get these products in the hands of dental students and show them that this is why we're using them. And talks like this tonight, I hope, give people confidence to go out there and say verbatim what I'm saying. So Riva Protect has high fluoride release. It's a low viscosity glass ionomer, so it flows into grooves, pits, and fissures nicely. It probably flows to the base of fissures and pits better than resin because it's more viscous. It'll get to the base, whereas something that's less viscous can get hung up somewhere in the middle of the fissure, leaving that bottom area still open and the process in there. And if there's stuff leaking in there, yes, we can find that we'll get caries under resin sealants. We know that. I don't think that you're going to find that will happen with glass ionomers. You will have more confidence sealing caries and sealing teeth that you don't think has caries. You'll get more confidence using these materials. This part, containing ACP, this is a new area. Everyone's starting to look at how ACP works on the surface of enamel for appetite strengthening. It's got it in there. I think this is huge. It comes in two colors, pink or white, and the setting is enhanced and strengthened. I've been reading some studies when you hit the sealants with LED curing lamps. Now, for some patients that are apprehensive, you're not going to go through this step, okay? But for the patients that are older, if you're doing 12-year molars, if you're sealing premolars, if you're sealing some primary molars in older kids, I would encourage you to start using an LED curing lamp. So we've got these silver fluorides now in the market. And so how do we bridge this level of care that I'm calling this hybrid prevention layer between primary and secondary prevention? And this is a case that I did. I observed this patient in a recall, and I saw that there was some staining, some demineralization in the grooves. And I said to the mom, let's use some silver diamond fluoride here to arrest whatever caries is occurring. And let's get the tooth to be free of biofilms that are obviously gone awry. It's caused the caries process here. And the mom consented, and we applied some silver diamond fluoride, and voila, you can see what happens. This patient returned after a week. I applied it a week early, and we see that we have some arrested caries in the fissure there. And I said, we need to seal that now. And so I used some Riva Protect, and there you go. Non-invasive dentistry. There's no reason to drill that tooth. None. And if you think about it, you can still approach this surgically even if this intervention fails. So let's say the sealant detaches and the arrest of the silver diamond fluoride goes away. This kid starts eating Cheetos morning, noon, and night. We've all seen it happen. You can still go to the surgical paradigm here if that's what you think is appropriate as the next step. But these non-invasive approaches leave us with a tooth undisturbed. And we all know that the more times we drill on a tooth, the closer we bring it to its demise. And in primary teeth, we all know that that's the case, especially first primary molars. You start drilling on that tooth, and it's a runaway circus. And we have to start looking at failure is not a detachment of a sealant. Failure is a tooth getting a cavity. If the sealant comes off, just put it back on. So let's talk about the SMART technique. I got a question here. Can I comment on the use of Riva with silver? I thought that the first case, that sealant case there, is a good first example. But SMART is the silver modified atraumatic restoration technique. SMART is a truly non-invasive, and it's a combination treatment. SMART is the culmination of understanding the limitations, liabilities, and inadequacy of traditional pediatric restorative dentistry. And SMART is a posterior restorative technique. I don't use SMART on anterior teeth. That's a separate conversation, but I just wanted to disclose that I strictly limit the use of SMART, which is silver modified atraumatic restorative technique. I solely use it in the posterior teeth. All the SMART restorations that I'm going to show you going forwards have been using SDI Riva, self-cured glass ionomer. I do have one case where I'm using their light-cured glass ionomer, but I disclose that. But let's move on here. So glass ionomers, I'm using these high viscosity glass ionomers, which are in the literature are proven to be very effective materials. They're improving every single generation. These materials by Riva are fantastic. By SDI, these Riva products are fantastic. I encourage everyone to use polyacrylic acid to condition and follow the steps on the manufacturer's card. It will only help the longevity of the restoration. And I think the closer you can keep to doing it by the textbook, the better off you'll be. But obviously every patient presents a different circumstance. And so that is also the beauty of glass ionomers. You can tailor them to fit how your patients. With composites, there's no tailoring how things are. You have to do the etch or the single bond or the one component bond, and then light cure, and then add your composite, and then do your light cure. You have to do these steps, but when you're using a self-curing glass ionomer, you minimize all that. And using these high viscosity ones, you can use your fingers, put them in with pressure. They're condensable because they are very, very highly viscous, and so you just have to play around with them. I suggest you get some extracted teeth, clean them up, get some silver diamond fluoride, get some of these SDI Reba products, and start playing with them on the bench so you can get to the mouth and feel confident that you know what you're doing. Vaseline is important to have here as well. You want to have some on your fingers if you're going to use them, and place them with your fingers so that the material doesn't stick to your fingers, and that you can really compress them into cavities and know that you're adapting these materials during that gelatinous phase, the setting phase, that you know that you're going to get them to where you need them to be. You don't want these materials to dry out, the self-cure especially, so you can take some Vaseline and place it on the surfaces of the exposed glass ionomer that's in the mouth so that they don't dry out during that setting process, and they're really great materials. So here's how we do this smart technique. I'm going to go a little faster here. We're running out of time a little bit. I like to toothbrush any cavity, clean any debris out that I'm about to treat. It also gives me an idea about the behavior of the patient. If they're going to be squirmish for toothbrushing their teeth, then I know that I have to tailor or modify my technique for this patient. Again, I may not use polyacrylic acid conditioner on this one. I may just put the glass ionomer directly into the tooth. But again, this is the ideal way. I'll isolate teeth with cotton rolls. I use a Garmer's roll holder. It works great. I'll apply my PAA for 10 seconds. You can also use etch for 5 seconds. Obviously, you're trying to minimize the contact of both of these materials with dentin. You don't want them on dentin. You just want them to be used exclusively on enamel. But again, patient behavior, placement, such as that, stick to the rules. I rinse, but I don't dry, and I press these materials into cavities. One trick you can do is I squirt the material onto the back of my glove. I don't bring these applicators and these capsules near the patient's mouth for infection control reasons. I don't want to do that. And they kind of look like scary instruments at first. So I think the more you can keep this to using your hands and very, very benign looking instruments, the better your procedures are going to go. Here's a 2-year-old. So we used silver diamond fluoride. We had some active decay. It turned the active decay arrested. This was hard. But this tooth needed a restoration. This is a 2-year-old, and we need to have something covering here for sure. Food is getting stuck in here, gummy vitamins, goldfish, whatever these kids eat now, all these processed foods, it's going to get stuck in these pits and fissures. So we went ahead, did our silver diamond fluoride. We applied it for 2 minutes as best we could. Again, it's a 2-year-old, so it was probably a little bit of a challenge here. We dismissed the patient. We brought the patient back a week later to observe the arrest, and lo and behold, we have solid arrest here. We then felt it was important to restore the tooth. So you can see in this picture, this is finger pressed, self-curing, high viscosity Reva. And we did the steps like on the page before. Very simple. And you don't need to sedate a child, the 2-year-old, to drill this away. Okay? We don't need to take those unnecessary risks. This procedure will work. It does work. So I got a question here. Is it necessary to use a coating agent with these glass ionomers? You can use, SDI has a great resin modified glass ionomer bonding agent that I think would be a fantastic coat on the top of it. Glass ionomers, and you're not using the silver part, I think it's great, but I think if you're going to use a light and you're going to use silver diamond fluoride or silver nitrate, you have to be careful with some of the cosmetic concerns of what happens when a curing lamp meets these silver compounds that are freshly laid down. But we can talk about that maybe in another presentation. But here's my smart technique. It's 2 quick appointments. So again, the first application is silver diamond fluoride or silver nitrate. The second visit is the confirmation of the arrest and decisions to apply GIC for restorative purposes. This tooth, I don't want this kid walking around with an open arrested cavity. It could return to active state. I feel sealing this in with a glass ionomer will keep this arrested and will keep this process. Because remember, the process started because there was a pit here. Okay, and you can toothbrush this great, but biofilms are going to reside in here, and we have to block that. And I'd rather the problem be on the surface again than on the interior. So we went ahead and we put glass ionomer in there. Here's are two surface smart fillings. Okay, no drilling at all, no shots. These patients come in with Mother Nature class 2s. And we employ this technology to work with Mother Nature and not work against it. There's no reason to drill away more teeth. I don't want to be the caries process. I want to be part of healing the caries process. So there's a question about toothbrushing. Any debris inside of the cavity to be treated? Does it mean you just use a toothbrush to clean the area? Yes, I just use a basic, brand new toothbrush. I'll tell you, Henry Schein toothbrushes. There's my shameless plug to Henry Schein. I buy bulk, the cheapest ones, and I use it specifically for that purpose, for these patients. I brush everyone's teeth to make sure there's no debris inside these cavities. There's a question, any recommendation of silver diamond product? Is it used first and a few weeks reopened and placed? Yes. I do this technique in a two-step. Some people are doing it in one step. I don't think there's any right or any wrong. If your patients don't show up very often or regular, if you have that type of population, then you may want to do this all in one step. My patients are good at saying how high after I ask them to jump. That's just my population. So understand your population and work with it, but you could easily do these procedures in one step. So this is a smart where I used Riva light curing glass ionomer, a resin-modified glass ionomer, which is not new, but a relatively new product that bridges between composites and glass ionomers. I don't think they're as effective as glass ionomers in fluoride release, but I certainly think they're more effective in retention of class 2 restorations, and I think you'll see that in the literature. This parent was very concerned with the aesthetics of silver diamond fluoride after hearing about, all the media hype turns teeth black, and I assured this mom that this tooth was going to come out perfect, and it did. You can barely see the silver diamond fluoride scarring there. But again, this was a two-step procedure. I had put the silver diamond fluoride down, I dismissed the patient, and then brought the patient back a week later and followed my normal glass ionomer steps, used some polyacrylic acid, applied the glass ionomer, finger pressure. I did have a matrix band. I just put like a very small sliver of a metal matrix band. You could use a de novo band around the tooth. You can do nothing. You can just use a little thin carver. If there's cavitation where the interproximal opens up a little bit, you can just take a thin carver and wipe it. But in here, I did use a matrix band. You just have to be careful when you're doing it. They can be a little irritating to gingiva, and you could set a child off. But if you do it delicately, you can do these procedures very, very atraumatically, and they come out fantastic. So normally you'll see a long reference list at the end of presentations, but I want to save everyone the reference list, and I want to encourage them to use the American Dental Association's evidence-based data website, because that's where I discovered all of this. It's all there. You just have to go to this website and start looking up these meta-analysis, these systematic reviews, these really, really high-level evidence-based concepts. You'll break them out into specialties, and then within those specialties there'll be categories, and I encourage everyone to go through there, because you want to be treating patients at the highest level of care. And I think that if you ignore the evidence and just go with what is a tradition, I think we're doing a disservice. Here's a question, what code do you use for GI restorations, same as composite? Yes, GI restorations are the same as composites. I think that language was written into the CDT book last year or 2 years ago, so there's no difference. There's some controversy maybe that calling this a restoration versus one of those interim therapeutic restorations or whatnot, but I don't read the CDT book as telling me that I have to use local anesthesia and I have to use a drill. I use the restoration language that I read in those books as saying you're restoring the form and function of the tooth, and that's exactly what we're doing. And if you're accepting PPO insurance or you're part of an HMO plan, as a lot of us are these days, you are accepting that when you place a restoration, you own this for at least 24 months. So
I don't buy this interim therapeutic thing, and I hope that we can get to the bottom of this misclassification of restorations and these concepts that we have about them. There is nothing interim about what I'm doing. Or you can think that all restorations are interim if they're just another step towards the caries process. Technically, I guess a filling is an interim step before the crown. But we need to battle this. So I encourage everyone to use all this modern technology we have, like this Viva Learning. I want to thank everyone for coming here. Use this website, and you'll find all the references. You'll see the paper trail that's left behind of how I came about this whole concept. Don't fear it. It works. You just have to put it into play.